Hello, and thank you for checking out FirstcallID, how to do an infectious diseases consultation in patients with a gram-negative bacilli bacteremia. I'm Paul Bunce, a specialist in adult infectious diseases and internal medicine. In this session, we'll spend the next 10 minutes or so reviewing the key aspects of an infectious diseases consult when you're asked to see a patient with gram-negative bacilli growing in blood cultures. If you haven't done so already, I'd recommend you checking out our first session on how to do an infectious diseases consultation, where we cover the general principles of ID consultations, whereas this session really focuses on cases of gram-negative bacteremia. And as always, this content is for educational purposes only. Please consult current guidelines and use clinical judgment in your own practice. And before we get into the details, just a few background points. First is that bacteremia with gram-negative bacilli is a commonly encountered scenario in hospitalized patients. An infectious diseases consultation is actually frequently requested at the point where GMB are isolated from the blood, but speciation and susceptibilities are still pending. And the question we're asking ourselves isn't just which antibiotic to use, but also why did this happen, right? So there's value in identifying the source of the mechanism of infection, right? Is this a monomicrobial infection, or is the gram-negative just the tip of the iceberg? And localizing the infection informs us on duration, follow-up, need for potential procedures or source control. And also knowing the source gives us a context as to what the likely pathogenesis of the infection is. Now here is an exquisite diagram illustrating the likely or common causes or sources of a gram-negative bacteremia. So central venous lines or catheters, such as dialysis lines or PICC lines, sinus or pharyngeal infections, head and neck infections in general, hepatopancreatobiliary infections, predominantly associated with biliary tract obstruction. Pulmonary infections rarely can lead to a gram-negative bacteremia. Colonic sources such as appendicitis, diverticulitis. Genitourinary infections probably the most common, so urinary tract infections in general. Pelvic infections in females can rarely be a source of bacteremia. Wounds such as those seen in patients with diabetes, but also postoperative wounds. And then cryptogenic, where we're just not able to figure out what the source is. So here are the key points or key components of our assessment of patients with gram-negative bacteremia. So first, we assess the clinical stability. Next, we take a history of the current illness, symptoms that the patient's experiencing, past medical history. And for patients who develop gram-negative bacteremia in hospital, it's good to review their course in the hospital as well as any procedures that they may have undergone while admitted. We're going to examine the patient with our general sort of approach, but also pay attention specifically to looking for the source of the bacteremia. In terms of investigations, we'll review basic blood work, microbiology, and imaging can be very helpful in identifying the source as well as the need for further management. And from this, we'll come up with our impression and our recommendations. So the first point is to assess the stability of the patient. Is this a life-threatening infection? Because the severity of presentation can influence the breadth of our empiric coverage. The idea is, what is the downside of being wrong? What if our empiric coverage doesn't actually cover for this particular pathogen? It's also important to recognize that in patients with gram-negatives in the blood who are on appropriate therapy, they can often decompensate for the first few hours after appropriate therapy is started. And it's not always a sign of inadequate empiric therapy. It can just be a consequence of the antibiotics sort of killing the bacteria and causing a stir up of the inflammatory sort of milieu. Our history will focus on the patient's current symptoms and the course of their illness. We want to see if there's anything that will localize the source of the infection, although recognizing that sometimes the source isn't obvious. I actually know two cases off the top of my head, patients who've had a lumbar puncture when they presented with fever and headache, but ended up having gram-negative bacteremia secondary to pyelonephritis. If a patient is admitted to hospital, it's important to review their course in hospital, again, focusing on any interventions that they've undergone during that admission. The past medical history will pay particular attention to gastrointestinal issues or genital urinary issues, especially interventions, procedures, or instrumentation. Any prior episodes of gram-negative bacteremia should be noted. It could possibly be the same source of infection. It can also suggest colonization with resistant gram-negatives if they've been identified in the past. History of malignancy is important to recognize, especially GI malignancy, which could lead to a variety of potential mechanisms of the bacteremia. Also commonly, anything that causes hepatobiliary obstruction via primary disease or metastatic seeding can also be a source or cause for the bacteremia. And then is the patient immunocompromised or immunosuppressed? And this can impact both the type of organisms that they're at risk of, but also could blunt their host response, and they might actually be sicker than you would initially anticipate based on their initial presentation. Our exposure history will pay attention to any healthcare exposures, antibiotic exposures, any interventions like I've mentioned, Also exposures such as environmental or travel-related exposures, food intake. And we'll take a history of substance use, specifically highlighting any history of injection drug use. And if patients do report a history of injection drug use, even asking specific questions about, how do they mix their drugs or dilute their drugs, because sometimes the substances or fluids that they're using could also be contaminated. Our examination will focus on the vital signs, including fever, but also hemodynamic stability and respiratory status. We'll inventory their lines, drains, and tubes, as well as recently removed lines. We'll do a careful skin and examination of the extremities, looking particularly for any wounds, ulcers, signs of soft tissue infection, identifying any lines like I've mentioned, and also any signs of endovascular infection. And then a particular genitourinary tract examination, just looking for presence of a catheter, also examining the skin and the perineum, because sometimes patients can present with soft tissue infections in the perineum that might not be identified with a cursory examination of the patient. The investigations we'll look at include the general things, so CBC, renal function, liver function, or liver enzymes. Renal function is important for our drug dosing. Liver enzymes are important because if they're abnormal, it could suggest the possibility of a hepatobiliary source of infection. It might prompt you to look more closely with imaging. We'll review the microbiology, so prior blood cultures and their results, the most up-to-date results from the current blood cultures that we're being called about, sputum cultures if it's available, urine cultures, wound, other collections if they've been obtained. It's important to note that urine cultures, when they're obtained after antibiotics have been initiated, can often be sterilized. I've heard that even after about 30 minutes of antibiotic exposure, the urine might be sterilized. And so that can mislead us into thinking the urinary tract might not be the source. With fluid collections, you also want to make note, worthy collections obtained from a freshly placed drain or an existing drain, which is likely to become colonized with other organisms. Imaging that we look at, it really depends on the case that we're seeing, presumed source of infection, and how confident we are if we've identified a source. So if a patient has symptoms classic for a urinary tract infection and gram-negatives in the blood, and we believe it's from a urinary tract infection, we probably don't need extensive imaging. But if the source is unclear, we'll proceed with a series of investigations. So a chest x-ray, although pulmonary sources are not the most common, you do want to check to see if there's any evidence for consolidation. The CT imaging of the abdomen and pelvis is one of the most routine tests when we're evaluating for a source. And in specific cases, when we want to take a closer look at the biliary tract, abdominal ultrasound might be of use. Additional tests will be guided by the presenting problem, what we're specifically worried about, as well as their clinical course. And so in addition to what we've said, you might want to do an echocardiogram if it's a recurrent or sustained bacteremia to screen for endovascular infection. Sometimes if there's a persistent bacteremia, it can be related to intravascular clots, so you might do peripheral Dopplers. Depending on the presentation, you might do head and neck imaging for a focus of infection, or sometimes even spinal imaging to look for a spinal infection. From all of this, we'll provide our impression and recommendations. Here we define the source or the presumed source of the bacteremia. And I say presumed because sometimes we'll be wrong with what our first hunch is. And so what is the most likely source and what are the other considerations? For antibiotics, these would be our empiric or recommended empiric antibiotic therapy, which is guided by a number of factors. So this includes the likely source of the infection, whether it's presumed to be monomicrobial or polymicrobial. Certain host factors might play a role in terms of their immune status or their exposure history. And it's important to recognize that this is our empiric therapy, meaning it's expected to be tailored once we have more information, in terms of the organism itself or its susceptibilities. And at this point, we might just nudge or give the sense that we plan to narrow or target our therapy when cultures become available, and even hint that we would anticipate switching to oral therapy if a safe oral option exists. I'll say at this point, it's sometimes helpful to even touch base with the microbiology lab just to get any additional information about the organism, things that they might not be prepared to release to them, for ready for prime time, but might be able to tell you about what they're knowing in the lab. In terms of further evaluation, I think this is where we fill in the investigations as indicated with what I listed above. So does this patient require repeat blood cultures or additional imaging? I'll say that the role of repeat blood cultures in patients with gram-negative bacteremia is uncertain, and I think it really depends on the case. For me, it has a lot to do with whether they show signs of clinical improvement or not. In terms of interventions, the idea is there a role for source control measures, such as removal of offending lines, draining a collection, the need for ERCP or anything to decompress the biliary tract, urologic decompression, or removal of any affected prosthetic material. Now, a few words about when to empirically cover for resistant gram-negative bacilli when we're awaiting susceptibilities. And I'll say this does really vary depending on the certain practice environment in which you're working, but some general principles. When to cover for these resistant organisms accounts for the risk of colonization with these organisms, as well as the downside of missing coverage for them. There's recent evidence that's evolving in terms of the need for coverage for resistant gram-negative bacilli versus tailoring to cover them once identification and sensitivities become available. I think this is something that is evolving. But here's just a few considerations that might influence your decision to cover more broadly or include coverage for these types of organisms. And this includes prior colonization or infection with drug-resistant organisms. Also recent healthcare exposure, ICU exposure where there might be some higher rates of colonization with drug-resistant pathogens, recent exposure to broad-spectrum antibiotics if they have devices implanted. Patients who are immunocompromised, you'll take this into account just in terms of their high risk for deterioration if they are not on appropriate therapy. And in some cases, travel or outbreak exposure might influence your desire to cover for these things as well. And here again are the key points to our evaluation of patients referred with gram-negative bacilli bacteremia. Once again, I think your evaluation really should focus on the likely sources of infection, any potential or additional foci of infection, the desired breadth of empiric antibiotic coverage, and the need for further evaluation and further interventions. In searching for references on this topic, I didn't come up with a lot of references that really address the specific approach to patients at this stage in their course. I'll say that UpToDate actually has a fairly good review on the topic if you have access to it. If you want to take a more of a deep dive from a clinical microbiology perspective, this clinical microbiology review on the pathogenesis of gram-negative bacteremia is also a very nice reference. So that's all for now. I'm Dr. Paul Bunce, and I want to thank you again for watching. Please share any feedback you have about the session or FirstcallID as a whole. And if you like what we're doing, please share, tell a friend, and take care.